Dr. Desai, I'm coming to you for some advice. I'm about to have a TAVR. Do I need to have a technetium pyrophosphate scan? Does it matter whether I have wild-type TTR if you're going to do the procedure on me?
Well, I think that it's an important consideration, I think, for the treating cardiologist to ask the question. I don't believe that every patient coming for transcatheter aortic valve replacement needs routine evaluation for cardiac amyloid. I think that the circumstances in which that should be considered, I think the populations which are not typical, I think are probably populations where we should think about the diagnosis a little more carefully. I don't think we have a large proportion of patients who have severe aortic stenosis and a pattern of progression of that disease over time that is really quite typical. And I would be interested in the opinions of Dr. Witteles and Dr. Hanna, but from my perspective, it wouldn't make sense or be economically appropriate to sort of test all those people. So the people that I would test are the ones that we've talked about. I think are the patients where the amount of hypertrophy is disproportionate, or there are other echocardiographic features that would suggest involvement by an infiltrative disorder like amyloid. And I think I also am particularly interested in these low gradient aortic stenosis patients, because I think the patients who have stenosis are a population that might be enriched a bit more for infiltrative heart disorders. But I don't know, Dr. Hanna, any other thoughts there, or Ron?
Yeah, no, I agree with Dr. Desai stated. I think that, patients with low flow, low gradient aortic stenosis have a greater likelihood of having it. The disproportionate degree of hypertrophy, what you expect to the degree of aortic stenosis, I think is a big one. And in the Columbia experience, they looked at the diastolic to tissue Doppler velocities, which were exceedingly low in the patients who had both aortic stenosis and the cardiac amyloidosis. And I don't remember what the cut point was, but those are the main things I would look at. I don't think we can promulgate testing every single person who's coming in for evaluation, but perhaps coming up with some kind of criteria and studying this prospectively would be a good idea.
Yeah, I mean, I think if we think about, why was the percentage so high, 16% of all comers in the study, I think none of us believe it's because transthyretin amyloid deposits are causing aortic stenosis. It's because you were picking out an older, predominantly male population with thick hearts and heart failure. And if you do that, you are going to pick up quite a bit of transthyretin amyloid. I think the points made by Drs. Desai and Hanna about the particular clues like the low flow, low gradient are very good ones. And I agree, I don't think we're quite at the point yet that we can justify universal screening on every patient being referred for TAVR. But I would say it should probably be universally thought of and looking for other signs to make you suspicious for it.